So first of all, thank you for joining us this afternoon for the discussion with the Centers for Medicare and Medicaid Services. My name is Asbel Montez, and I'm the Senior Vice President of Strategic Initiatives and Innovation for Acadian Companies, and we are proud to be a sponsor of the Texas Association of Health Plans. Joining me today is Calder Lynch, who most of you are here not to see me, but to hear from him. In January 2020, Calder Lynch was appointed the Deputy Administrator and Director of the Center for Medicaid and CHIP Services, where he serves as the agency's senior executive overseeing the Medicaid and Children's Health Insurance Program. Calder began his career at CMCS in May of 2017 when he was named the Senior Counselor to the Administrator. Calder was named Acting Deputy Administrator and Director of CMCS in May of 2019. Though prior to his federal work, he was at the Nebraska State Medicaid Director under Governor Pete Ricketts. And prior to his work in Nebraska, Calder served as the Chief of Staff to the Secretary of the Louisiana Department of Health and Hospitals. Have to give a shout out if you don't see his painting in the back and the pelican, shout out to Louisiana. A Louisiana native, Calder earned his degree in business administration from Louisiana State University and his master's in health administration from the University of Alabama, Birmingham. So let's get right to it, Calder. And also, don't you just love, I just have to say, don't you just love having to sit through while everybody talks about your accolades and kind of sit there and try to be humble through the process? But you've had a great work, and we appreciate you being here today. As a reminder to our audience, at the bottom of your screen is a Q&A button. So as Calder is talking here, if you've got Q&As, I will be moderating the question and answer piece. If you will put that in the Q&A and not the chat function, we will make sure that we get to as many of your questions as possible, as Calder will be answering questions. And I will moderate those questions as appropriate. So an opening question for you, as well as I know we have a lot of topics to cover today. But if we can get started with you giving an update on some of the major initiatives, and I know the new Medicaid managed care rule that was just published is probably of interest to the group and to our audience today. So Calder, if you'll take it away from here and give us an update.
Absolutely. Thanks so much, Asbel. It's good to see you, and it's good to be with all of you today virtually. And we are also having beautiful weather here in DC, so I hope folks across the country are getting to enjoy a little unseasonable warmth this November. Well, there's certainly a lot to cover from the perspective of what's going on at CMS, some of it being very timely, I think, for this audience. But first, let me just take a moment to reflect on what has been truly a challenging and extraordinary year, I think, that we've all had working through this public health emergency and responding to this pandemic. I had only just been permanently named to the Medicaid position back in January, when fairly in short order, it became clear that we'd be responding to a different type of emergency than we were used to. It's not uncommon for CMS at the federal level to be supporting states with, localized, whether it's hurricanes or floods, but quickly, I think, also recognized that this was going to be something that the entire country was faced with and would require a different type of response from the federal government. So in March, we quickly pivoted to really focus all of our resources and efforts on helping states plan for and prepare for the response to the pandemic, as well as the Medicaid side, as well as figure out from our Medicare and clinical and safety perspective at CMS, making sure we were removing any barriers to being able to effectively provide care, issuing blanket waivers, and really helping the health system prepare to respond. On the Medicaid side, we created toolkits, checklists, really tried to streamline the process, recognizing that all states and territories were going to need support and flexibility, enabling us to be able to, since March, approve over 500 various types of emergency waivers and other state flexibilities in an average of less than a week for each one. I mean, really just a tremendous effort by the team at CMS in responding and supporting states. And those have helped to do things like expand access to telehealth coverage, remove barriers to reimbursement for telemonitoring, telehealth, teleneeds assessment for people in our home and community-based waivers programs, streamline provider enrollment to expand access, streamline eligibility requirements to come into compliance with new federal requirements, just a lot of things that states need to do to prepare and be able to respond effectively. More recently, I think our work around COVID has focused on preparing for the next phase of the federal response, which will be ensuring a successful distribution of a safe and effective vaccine. We've seen some very encouraging news just even today about the prospect of an effective vaccine on the horizon. So we want to make sure from the payment perspective that we are ready to support a successful distribution. We recently published the CMS payment and coverage strategy for the eventual COVID vaccine, outlining how Medicare would approach the payment for administration of the vaccine. Of course, the vaccine itself will be purchased by the federal government, but we'll still need as payers to collectively ensure that we're supporting its administration. So having, payments for various dosing, making sure that that payment rate is reflective of the requirements that will come in terms of reporting and ensuring follow-up for 2-dose vaccines. And we released toolkits for providers, for payers, as well as for states on making sure that we're prepared to have a successful distribution strategy. So definitely would encourage everyone to take a look at that if you haven't. Look at the Medicare payment approach as a potential model and make sure that you're prepared to support the successful distribution of the vaccine, which will hopefully be very, very soon. We are also, also preparing for making sure that we can pay for and cover new and innovative therapeutics for COVID-19 as they come online, and making sure that we've got strategies to pay for those no matter what setting they're being delivered in. So we recently issued an interim final rule that sought to address barriers to reimbursement for those types of innovative therapies that are coming online in Medicare, and are encouraging states to also take a look at their programs and make sure that they don't have barriers in place to ensure that our beneficiaries can access the latest treatments when they're available. So obviously a lot of attention focused this year on COVID. I don't want to belabor the point. But we're even amidst that, we're continuing to push across our various strategies, I think all aimed at making sure that we're promoting a more value-driven healthcare system. That's been, I think, a bipartisan cross-administration effort to ensure that the billions of dollars that, and now CMS, $1 trillion agency, are invested toward improving outcomes and overall making our programs more sustainable. So things on that front that have been very focused, and we'll talk more about today, I'm sure, is making sure we're documenting the lessons that we're learning through the Innovation Center and Medicare on alternative payment methodologies, and that we're informing all of our future efforts toward a more value-driven healthcare system, that we're removing or making course corrections on, federal administrative requirements that are getting in the way of effective delivery of care. That's part of the news today I want to talk about with the final changes to the Medicaid managed care rule, as well as making sure that consumers are fully engaged in healthcare decisions and are informed and able to make better decisions about their care and lower costs in the healthcare system, which we marked, I think, recently with our really monumental price transparency rule as a follow-up to our prior efforts to promote price transparency at the provider setting. So all of that, again, really aimed toward making our healthcare system more value-driven. I'll quickly, just because it's so timely, provide a quick snapshot of what happened today. I mentioned that we issued the final Medicaid managed care rule revisions. These were updates to the rules that were promulgated back in 2016 to try and reflect some of our lessons learned. I think pull back where we felt like maybe there was a little overstepping in terms of federal requirements that were a little too prescriptive, and making sure states we were focused on more of an outcomes-based type of oversight perspective. So doing things like giving states more flexibility to do some narrow rate ranges to promote plan competitive procurement, and making sure that they can drive the best value for their programs. We made adjustments. The prior rule had phased out the ability to do pass-through payments in managed care, which were simply where the states were just passing through supplemental payments through the health plans with no ability to really manage those costs. Those that we recognize have been important sources of funding, even while we want them to get more toward more value-driven over time. We want to give states that are newly transitioning to managed care, or that are newly bringing populations or services in, and maybe weren't part of that initial transition window, time to transition those payments to a more value-driven state-directed payment methodology. On that front, we made some changes on the state-directed payment requirements for Medicaid, giving states some additional flexibility to do multi-year rate approvals, as well as not require that they go through that CMS preprint and approval process when they're simply requiring health plans to follow state plan approved rate methodologies, including those that may be operating under a value-based arrangement. We made some adjustments to the network adequacy standards for Medicaid and CHIP. The prior rules had required states to set their standards based solely on time and distance standards. We wanted to give states the ability to set more dynamic quantitative standards that could better measure access, whether it's time for appointments or ability to see a new provider, as well as take into account access points like telehealth, which has become even more important as we've observed during COVID-19. Some changes on risk-sharing mechanisms expressly prohibiting states from imposing risk corridors retroactively after the results of the rating period are already known, which is really aimed at ensuring program integrity. Going forward, some small adjustments to the upcoming requirements to establish quality rating systems for managed care plans, really maintaining that requirement, but making it clear that we would set a federal floor of a minimum set of measures that would align with our other quality measure programs across CMS so that there's general alignment between the various types of quality programs. And then beyond that, just some more administrative changes to align, for example, the appeal and grievance timelines between managed care and fee-for-service, making those consistent, pulling back on some of what we felt were overly prescriptive federal requirements around beneficiary information and communication, as well as giving states the ability to create more incentives for plans to adopt things like digital provider directories in exchange for having to print and mail them fewer times. So just some modernization, I think, reflecting kind of the evolution of the healthcare system and market in Medicaid. That's a final rule. It goes into effect. There's various timelines outlined in the rule. You can see that. There's a fact sheet up on cms.gov that goes through that. But all really, again, geared toward making sure that our programs are driving toward value and quality and sustainability, which I'm sure we'll talk more about as we get deeper into the conversation, but just wanted to highlight those few things.
Hey, thanks, Calder, for that. So, of course, I have lots of questions, and I'm sure everybody has been able to read the rule, as many of us probably have not, and we're just getting a summary, and we've kind of worked through that. But I do have a few questions because you started talking about a few pieces, and since we're talking about managed care, I'm going to ask you a question. And as a reminder to the audience, if you have some questions, we're moving into the Q&A now. So if you've got some questions for Calder, please utilize your Q&A button, and I will be paying attention to that and moderating appropriately. So let's talk about program integrity surrounding managed care. What is happening at CMS right now regarding the oversight and giving your role to ensure program integrity in the managed care space?
No, it's a really good question. I think we are looking at it from a number of fronts. There's your more traditional type of program integrity oversight, which I don't think is necessarily terribly different than the work we need to be doing in the fee-for-service program in terms of making sure that we're rooting out fraudulent providers, we're doing the appropriate types of claim review, we're making sure that there is the right level of oversight at the plan and state level, no matter what delivery system is in place. And our Center for Program Integrity largely leads those efforts. And I think we've really tried to focus on helping equip states who are moving toward more managed care delivery systems to think differently about program integrity and making sure that they're equipping and overseeing their plans to do an effective job on that front. But there's also other aspects to it too. Certainly we want to make sure that on the front end, we've got the right standards and processes in place to make sure that the folks that we're enrolling in Medicaid meet the eligibility requirements, and the states are doing the necessary renewals and income verifications to ensure that there's integrity in the eligibility process. We saw some very disturbing results of the first payment error rate measurement reviews of eligibility that occurred post ACA implementation just last year, with error rates in the first cohort of states that we saw well above 20% on the eligibility side. That doesn't necessarily mean that 20% of folks who are enrolled shouldn't be, but that in 20% or more of cases, there were errors in the process. Some information wasn't appropriately verified. State did not conduct a timely renewal or redetermination. So we've been really focused on making sure states have the right guidance to support those efforts. Now, obviously, COVID has shifted some focus as states are now now, as a condition of receiving enhanced federal funding, not allowed to disenroll individuals outside of some limited circumstances. So we're working to make sure that, when the public health emergency does eventually end, that states are prepared for and equipped to quickly return to normal eligibility operations and ensure that folks, you can conduct the necessary renewals, income verification, so that we can get to a baseline on short order, while also making sure that that is a smooth and successful an orderly transition for the beneficiaries as a top priority. So you'll see guidance from us before the PHE ends on that front, really laying out our expectations for how states should return to more normal eligibility operations post PHE. The third piece I would say on that front is around how we finance the program, which I know has been a point of a lot of discussion over the last 12 to 18 months, both within and outside of the proposed MFAR rule. It is a partnership between the state and federal government where we're each putting in a contribution to the costs. And when that sort of partnership is eroded based on different types of financing schemes that subvert the requirement for states to contribute to the non-federal share, it creates perverse incentives that drive up costs and ultimately make the program not sustainable and put CMS in the position of having to clamp down in ways that might not be as effective, at promoting value. Whereas if we were all kind of rowing in the same direction toward lower costs, we could share those incentives. So I think we want to make sure that there's transparency and integrity in that process. That where states are sourcing non-federal shares coming from permissible sources, and it's not creating incentives to drive dollars back to providers that in ways that aren't linked to utilization and, importantly, quality and outcomes. And so that was really the impetus behind the proposed MFAR rule. Obviously, we got a lot of feedback about that rule, and we heard a lot of concerns that it could have created unintended consequences for safety net financing, and we know how fragile that is. So as we shared a few months ago, we pulled back and said we're going to take more time, and we're still looking at that to figure out what the best next steps are. But the goals are still the same, I think, in terms of making sure that there's integrity in that process and that we can all have trust that the program's being financed appropriately so that it can be sustainable for the long run. And certainly, we continue to do that both in and outside of managed care. It's important to make sure that that's happening broadly. But I think all three of those fronts we are looking at when it comes to program integrity.
Thanks, Calder. And I'm not going to ask you any questions on MFAR. But we have a few questions that are coming in right now. I'm being facetious because, boy, we don't want to get into the MFAR questions. But if they come in, I will be more than happy to lob them your way. First question we had is, where can we find the final rule set for modernization? So if you just go to cms.gov and go to the newsroom, you will see the press release that was issued today, along with a fact sheet that was issued today, and a link to the actual rule, which is posted at the Federal Register. And if I'm knowing Jamie correctly, who's the CEO of THP, she'll probably will get that out to all the attendees. And especially if you're a member of THP, I'm sure that's coming or it's already in your mailbox. One more question that we had is, besides error rates, does CMS routinely monitor the other type of error or missingness whereby eligible people are not enrolled in Medicaid? If so, could you share some statistic with us?
Sure. That's a difficult thing to measure, right? Because you're talking about, folks that you don't necessarily have a view into. I can tell you that there has been a lot of focus on making sure that we are reaching children who are eligible for the program and trying to close that gap. I think we invested about $45 million this year into Medicaid and CHIP children's outreach grants. I've personally done a ton of radio media tours during kind of the back to school session and making sure that we were getting the word out about the importance of getting kids enrolled, especially during this pandemic where we see so many folks are foregoing necessary preventative care. We want to make sure folks are enrolled in the program and working with states to identify those hard to reach groups. A lot of focus, for example, on Native American populations. And we do try to use data to drive and target those outreach efforts and making sure that those grant dollars are flowing where we think there's the greatest need and the greatest unmet need. But it's a hard number to figure out exactly what that percentage is if you don't know what the denominator is, and that's not always clear. I can tell you that we publish monthly enrollment data and figures And we've started drilling a little bit deeper into that data and providing a little bit more context, state-by-state analysis, looking at how it's trending related to things like unemployment data. It's a little skewed right now, right, because no one's able to disenroll anyone because of the MOE requirements. So enrollment has been tricking up pretty significantly since March. We're now at, I think we've gained almost 4 million new enrollees since that time. So I think this is going to be a difficult sort of set of data to try to decipher because of all the noise that's created there. But we certainly want to make sure every eligible child and individual has the opportunity to enroll.
Perfect. Well, I'm going to, and for the audience, if you have more as we continue, but we're going to kind of jump topics here and move to interoperability and some of the interoperability rules that are out there. So can you touch on some of these new rules? Now, there's many of them. So Calder, if you can kind of give us a 20,000-foot view of what CMS is attempting to achieve with these new rules.
Yeah, so a few things, I think, and I'll speak at a broad level because I'm probably not the best person to get into the weeds of the rules, But I think what the administrator's vision here is to, well, one, let's take a step back for a second. So the federal government has invested billions of dollars into the adoption and proliferation of electronic health records to, I would say, pretty mixed results. In the sense that we might have created electronic health records, but now instead of physical filing cabinets where records are locked in, we've got digital filing cabinets where records are locked and siloed. So, I think the goal is if we're going to, given that we've invested so much of federal resources into this, we want to make sure that there are consistent standards and expectations that the patient owns their medical information and record, and that it can flow with them no matter where in the healthcare system they're receiving services. Whether they move between systems, providers, that their information can flow with them in a standards-based way, that they can control who it goes to, and that they can take it with them across all providers. And the way in which we really envision that happening is by creating a requirement that these systems communicate through a standards-based API, which can be an interface that you as a consumer can authorize whatever application is you want to use to manage your records, to pull down, access those records, have them be transmitted in a standards-based way, and then direct where in the healthcare system you want them to go. And so the requirements are really geared around making sure that the folks we regulate, which are going to be your states, your providers, and your health plans, that their systems enable that to happen, that reality to happen. And then from there, the hope is that by creating those standards and those requirements, you would see investment in creation of new tools that could really harness the power of that information and data and help individuals manage their healthcare conditions, help identify unmet needs or care gaps, and really help identify new and innovative ways to take care of complex populations. So those at a high level, I think that's what we're really reaching to try to do through those rules.
Perfect. That was a 20,000-foot view. Thank you for that. I'm going to switch topics now and go to value-based and value-based the payment system, of which managed care organizations, health plans, of course, I'm a provider of care. So a lot of times I have to now take my hat off of my provider perspective and moving it to the health plan perspective side. So there's a lot of conversations that are happening in the state of Texas. And I know most states are in the same place about the need to move away from the fee-for-service environment and to more of a focus on a quality. And however that is, and Centers for Medicare and Medicaid Innovation have been trying to do some of this stuff, as well as insurance health plans, in my opinion, have probably been a lot farther along. And sometimes CMS and Jamie's probably like, oh my word, I can't believe Asbel's saying this, but most people that know me I know I'm pretty blunt about this. But sometimes the federal players lag behind commercial carriers and others with innovative payment models. So explain to me, what are your perspectives about this shift in the healthcare system, and what is CMS's current approach? Because I know there's a lot of dialogue about CMMI, some of these models not getting the returns. I'd be very interested in hearing your approach on this, Calder.
Yeah. So I think we have learned a lot collectively as a healthcare system over the last decade around value-based care and reimbursement. And I think we still believe that there's great promise in moving away from fee-for-service and really trying to make sure that the way we're directing dollars to the system are incentivizing the outcomes we want to achieve, right? Which is better quality, better outcomes, lower cost. The devil, of course, is always in the details, right? And a great model and approach can be stymied by poor attribution models or poor risk adjustment algorithms that fail to take into account the complexity of the underlying population and can just completely throw the incentives off and dissuade participation from well-meaning and successful providers. So there's a couple of things I think that broadly we've learned, right? We've learned that those details are important and we've got to get them right on the front end. I think we've got to make sure that providers themselves have a feedback loop that is timely enough where they can make adjustments in their care delivery models or how they're engaging patients so that they can be successful, right? And it's not after the fact when it's too late to do anything about it. So making sure that there's data in the system and it's flowing in a meaningful and actionable way back to providers to help them understand their performance in a value-based model in more real time. The third is, I think that we recognize is that providers they need to spend their time taking care of patients. That's what they're trained to do. That's what we pay them to do. And so in order to enable that, we've got to make sure we're not adding more administrative complexity that adds value. And so, making sure that the quality measures are clean and consistent, that they're not overly burdensome, that they are not overly numerous are important, that making sure that there is alignment between payers is tremendously important, and something that we've stressed a lot in our recent guidance is that whether you're a Medicaid, Medicare, private payer, a lot of these providers are serving patients across that spectrum. And while the complexities of the individual populations may be different, the way we've structured incentives and the types of interventions that providers need to engage in need to be consistent in order for us to be successful in moving the ball forward. So I think those are some of the broad lessons that we've learned through CMS, through Medicare, and we want states and Medicaid managed care plans and others to apply them in a consistent way. We just last month issued guidance to try for states and distill those lessons down in a way that can be accessible to states no matter where on the spectrum they fall around the sophistication of their value-based adoption strategy. But really the call to action there is for every state to have a strategy to understand where they are on that spectrum and to see how they fit within the various types of authorities and payment models that exist and develop a plan to move down that path. And so we tried to outline what are the various authorities, whether it's managed care, fee-for-service, how do you access them, what populations can they be applied to, how can you structure different types of payment models, what have been the lessons we've learned from Medicare or elsewhere, and how do you apply those? So our hope is that as a catalyst for further conversation at the state level and identification of specific strategies to move that forward. But we're going to continue to learn, derive lessons, and try to make sure that information is available so that we can continue to get better as a healthcare system more overall.
Perfect. And I'm going to have a follow-up here to what you're just talking about. Another reminder, if you have questions, please utilize the Q&A and we will get to your questions as soon as possible. I am going to, I'm going to add a follow-up question here, and then I'm going to get to someone that just asked a question relative to telehealth. So Texas is having a lot of aggressive targets to move from this value-based payment system into some of these alternative payment models. And you alluded to a little bit about it when you were speaking here, Calder, about some of the challenges and nuances. But because we've been working on this for the past decade, and you're really not seeing, a major broad adoption to this, what are, at your level, what are some of the other obstacles that you might be seeing? I can tell you what mine are, and I might opine on that because I think politics gets involved in this sometimes, of unfortunately it being a shift, of a major shift as well. And what other than guidance and different things like that are you guys looking to do to encourage this movement? Are you looking to do more within the CMMI space? I know there's a relook and a restructure of that to try to get more adoption of these APMs and out of the fee-for-service environment. Can you opine a little bit on that?
Yeah, I think it's going to be multifaceted. I don't think there's any one way we can do this, or a hammer that we can kind of bring down that's going to all of a sudden cause a mass proliferation of APM adoption. Every community is going to be a little bit different in terms of like the way their provider systems are structured. Is it one provider that's dominant? Is there one private payer that's dominant in the region? Those nuances will mean different strategies may need to be deployed, and there's different market forces at play, right? So I think you just first have to start with an understanding of that dynamic and a respect for it, and kind of an acknowledgement of that reality in your planning efforts. I think giving the states the tools and the guidance is a good first step. I think setting clear targets will be the next step around what we expect in terms of APM adoption, looking at where we can create incentives, right, to help drive that forward and remove barriers. I think we're looking at whether there are things that we can provide states around tools to help make data more usable for them and for providers, to help understand their performance of their providers under various APMs. That's something we're looking at that might be useful in helping spur that forward, showing them what Medicare models would look like in their programs. Some targeted types of technical assistance and very focused, kind of expert learning with states. We're looking at how do we provide that types of support. So all of those things are on the table. I will say you talked about barriers. And I think that one thing we just have to be really honest about is, when we're talking about a new payment model or the way states are looking to sort of direct dollars through the system, I think an assessment of what really are the goals there and what's driving it. Is it really, we want to direct dollars toward the providers with the highest outcomes and the most lowest costs and the best results? Or are there influences on how those dollars are being distributed that are tied more back to financing and how the state is generating the non-federal share? Because if that's the case, those two things are going to end up being at odds with each other, and you're not going to be as successful. And I think that's just something we have to be honest about and figure out how do we address it, because I understand too that at the same time, those dollars are very important to the overall healthcare system, and we need to make forward progress. So I think just kind of being honest about that and figuring out how to work within to make incremental progress where we can is going to be really important.
And there's the MFAR. Sorry, that was a really good segue there as well. So I am going to, good questions. I'm going to move, because this question is really moving more into some of the COVID related questions that we have. So we have a question that said, you mentioned the new rules address telehealth. Can you speak about what you've seen at CMS related to the uptake of telehealth during the pandemic and any future work to continue to expand?
Yep. So I think it's first important to remember from the Medicaid perspective, there are no real federal restrictions around telehealth coverage, and states have for a long time had the ability to have parity in telehealth coverage and payment. But we have seen, because there's just so much flexibility, obviously the result is you've got a lot of disparate types of policies across the country in terms of whether states just had restrictions on which providers could provide telehealth, where it could be provided, and also maybe reimburse for it at some kind of discounted rate that disincentivizes its adoption. Many states quickly sought to strip those barriers away, and we made an emergency state plan amendment authority available to quickly allow them to remove those restrictions out of their state plans, increase reimbursement, provide parity, such that since March, we have seen a 2,500% increase in telehealth utilization in Medicaid. So that's a pretty tremendous, based on the data the states have reported to us so far. So that's a tremendous increase. On the Medicare side, there were more federal restrictions on, who could provide telehealth, where it could be provided, what beneficiaries were eligible for it, that we sought to strip away in the early days, whether through legislative action or through 1135 waivers, that we could issue the blanket waivers or other emergency rulemaking authority. We have been undergoing a month-long process to assess which of those changes need to be made permanent based on our lessons that we learned. I think it's clear that there's no going back to the pre-pandemic days when it comes to telehealth. It may not, but there may be some things that we need to course correct a little bit, to make sure that we've got the right guardrails in place. Also, some of it may require legislative action to make permanent as well. So we'll have hopefully some recommendations for Congress too. But I think we are clearly recognizing a new reality when it comes to telehealth coverage. What's going to be important is making sure that that opens up access broadly for folks in the programs, and that we aren't just creating new disparities, for access and coverage for telehealth, but that we're using it to also reach harder to reach populations and bringing them in for care, and that we're closing those gaps. Certainly, it's been an important part of our ability to address foregone care, during the pandemic, where folks weren't coming into the doctor's office, but you can't deliver a vaccine through telehealth. So it's only, it has limited applicability. So we've got to also make sure that we're closing those gaps as well.
Perfect. And a follow-up to that as well. During COVID, did you see states asking for the same type of flexibilities, or did they vary?
Both. I think we created templates that were checklists pre-filled out for different types of authorities, whether it be the 1135 disaster waivers that could streamline provider enrollment, allow out-of-state providers to come in, remove prior authorization requirements. Many states just went down the list, checked the box, and adopted some similar authorities. Many states, we also have a process for adopting that emergency flexibilities in the home and community-based waiver programs called the Appendix K. And many states use that to allow for retainer payments to home and community-based services providers, like adult day health centers that had to close during stay-at-home orders to help make sure that they could be sustainable, and those access points would remain in the community once folks were able to return, back into those settings. So there were definitely many states that had, the same types of authorities, but there were also some unique things that states sought to do based on what was in their current programs. Like they might have had a very particular type of rule around telehealth coverage that they had to address that was unique to that state. So it did vary a little bit depending on what the baseline was.
And some of those challenges are, as we're talking about telehealth and some of the waivers and what was done, because I know that that is what this real-time demonstration in this public health emergency has indicated. That there's a few different things that I want to ask you about. One's broadband, and I was talking to one of your counterparts at HHS about a stakeholder engagement, because it really requires more than just HHS and CMS. Is CMS involved in that? Because broadband has been a major issue, especially in some of the rural areas, and not just necessarily the rural areas, even in some of our urban environments, of the access points. Are you guys engaged in that, and how, and what do you think is going to transpire out of this, what I call internal stakeholder meetings that you guys are having?
Yeah, I wouldn't say that we are a leading sort of driving force in that effort, right? Because it's probably more FCC and others around, where those resources lie. There may be roles for states to think about building connection points for, EHR adoption at rural communities, and thinking about how to help support some of that. And we can, in some cases, make 90/10 federal funding available for some of those types of activities, not broadly for broadband deployment in the rural areas, but certainly to help build connection points to the healthcare system that benefits Medicaid beneficiaries. I think we want to make our data available to help inform those policies that show the impact of what those lost or what the impact on access looks like when that isn't available. And we know rural communities in particular have struggled, even before COVID, right, in terms of making sure that there is sufficient access for patients. And that's part of why earlier this year we released the chart model, because we also recognize that the solutions to solving those problems are going to be very localized. And they're going to require bringing together the hospitals, the health systems, the payers, the state, to figure out how to redesign care delivery and reimbursement to work for those communities. Because just as we're talking about this movement away from fee-for-service broadly, volume-based reimbursement is probably even more challenging in rural areas that just can't support the volume of an intensive inpatient hospital or certain service lines, but need to have access points and referral points to make sure that they're all able to offer a complete continuum of care to those residents. And so the chart model is aimed at giving communities significant investments in seed funding to design and deploy a different type of system and provide them with stable, reimbursement and funding to help through that transition. So we're excited about what lessons we can learn from that that process. And I imagine part of that is going to be assessing, what does the broadband infrastructure look like in that community, and what investments do we need to make in ensuring that they can support the model of care that we want to have. And then that can help inform where we need to make further investments from a federal government perspective. So applications for a chart are due in February. We definitely encourage communities, rural communities, to take a look at that and see if they are interested in pulling together the sort of type of multifaceted group that would need to come together for that application.
Perfect. And while we're talking about the telemedicine piece, of course, we've noticed not just with the unprecedented use of telehealth, but there's also been a decrease in patients accessing preventative care. So what have you seen at the federal level within your data, and what has CMS done to respond to this because of this unprecedented use in the PHE?
So it is actually one of the things I'm most concerned about, but also most encouraged by the enhanced ability we now have, I think, to drive data-driven decision making in our programs, particularly in Medicaid, which of course is where my heart lies. We have only just in this last 18 to 24 months gotten to a point where we have every state reporting claims and eligibility data into CMS on a timely basis, and have been working to make sure that that data is complete and is of a usable and research-ready quality. And so we began publishing, analytic files to the research community to help drive better policy making and decision making around Medicaid. And we have also been able to use that information in more real time to understand the impact of the pandemic on our population. And I think, as you've probably seen, we've seen some very concerning trends, especially when it comes to kids, which, is the majority of Medicaid and CHIP, where we've seen tremendous declines in immunizations. I think like a 60-something% decline in preventative dental services, declines in well child screenings in the March to June timeframe. Now, some of that's starting to trend back up, not enough to make up for the care that's been lost. And so recently, the administrator, we published that data, and she issued kind of a call to action for communities and states to come together and develop a plan to make sure that we're able to help address these care gaps and get kids caught up, because as we all know, these can have lifelong consequences for learning and development when we're not able to catch some of these things, these types of screenings or issues early. And schools are such an important access point for healthcare for particularly low-income and minority children. And we know that there's been an impact on school closures and having those access points. So even if schools haven't returned, I think it points to the need to get kids back in school, but also, even for schools that are still in distance learning, they need to have a plan, and communities need to have a plan to make sure those access points are still available and that we're helping those kids make up for that lost care. So we're going to continue to monitor that. We're now beginning the point where we can look at the map and see which states are returning to baseline faster than others, so that we can target our outreach to the states that aren't and help figure out what we can do to support them and making sure they have a plan to get kids caught up on that care.
Now, with that piece of it, are you offering states, and I was on a phone call earlier with some Medicaid, and they're kind of trying to think of some innovation, and a lot of the times it was going back and said, well, we have to see if the state approves some modification like this or what have you. So what flexibilities are you continuing to offer to the states to really begin to think outside this box? Because that seems to be a deference point to managed care as well, kind of relying on the state. So how are you guys reiterating that from and the guidance you're giving from the federal level?
Well, one, just reminding states that, we're still in the public health emergency, and that gives us a lot of flexibility to, expedite and grant different types of waiver requests, state plan amendments, address, barriers to telehealth, address reimbursement parity issues that are preventing you from going and offering alternative sites of care. Many of the Medicare blanket waivers that allow alternative sites of care are still in place, that allow out-of-state providers to come in are still in place. So we really, I think, taking advantage of many of those existing flexibilities to ensure that you're able to do that. And then I think but the big piece of this that really is going to move the needle is, and it's not something we can do necessarily, we can certainly support and cheerlead, is developing local partnerships and collaborations between schools and communities and providers and states to identify and target and get folks caught up on some of these care, open different access points. I don't think there's necessarily federal barriers to that. It's just, kind of the wherewithal and action to kind of get that happening. And many states are doing that. We've seen some great examples where schools are setting up clinic tents even when they're closed, to help get care delivered, mobile units out, partnering with community health centers. There's a lot of really cool innovation happening, and we just need to make sure that we're taking advantage of that and replicating it.
So while we're talking about school health, a question just came in, Calder. So any comment on school health as a safety net healthcare provider for children, especially in the lower socioeconomic strata, and any plan to enhance support for school health?
Yep. So I think we do see schools as a really critical access point for kids, and has been for a long time. And I think, we have released guidance to states, particularly focused around behavioral health, mental health, and addiction services, and the importance of utilizing schools to help address those needs, which often go unmet. We did that in coordination with SAMHSA. So I think there's a lot of tools in the toolbox that are available for states to think about how to set up good school-based coverage programs, help enable and equip their schools to be prepared to be a provider, to bill, not just Medicaid, but other payers as well, so that's sustainable. At the same time, we've also got to make sure that there is transparency, that there's referral points where necessary back to the primary care medical home for a child, that we're not duplicating those types of settings, and that we're banking legitimate healthcare costs and reimbursing for what Medicaid should be, and not supplanting what should be funded through other funding sources. So, there's a bit of a balance on that side of making sure that there's good program integrity oversight, but I think that there's a lot of tools available and best practices that we've made available to states to emulate.
Good questions coming in as you have them. We have just a few more minutes here. I'm going to follow up while we're on this conversation of the public health emergency. Keep your questions coming. The COVID-19 crisis has shown a light on the reliance of institutional services like nursing homes. For years in Texas, we have focused a lot of efforts on rebalancing the system and ensuring access to community-based care, but it feels like there may be a need to look at that rebalancing effort again, Calder. So it's been a while since we've had this conversation. Why do you think there is this reliance, and what do you think we can do to continue or revitalize the movement towards more home and community-based care?
That is an excellent question, and one that we have been having a lot of discussions about at CMS over the last few months. As you are right, I think that COVID-19 has shown a light on, I think, some of the challenges that have long existed in our institutional long-term care systems that I think are the result of just, chronic underfunding, and as well as, not tying the way we our dollars to the outcomes that we want to necessarily achieve, right? And it's not just, it's funding for the system as a whole, and making sure that there is sufficient home and community-based services supply, and that we are setting quality and safety standards consistent with what our loved ones deserve, no matter what setting they're being served in. So to that end, there's a few things. We just last week actually published a new LTSS rebalancing toolkit for states that sought to compile what we think are some of the leading best practices across the country from states that have been successful in rebalancing efforts, and very clearly identify what are the tools that states have at their disposal through different types of federal authorities to help incentivize return to the community, institutional diversion, ensuring that you've got an adequate supply of HCBS direct care staff, none of which is easy, right? It requires concerted investment and effort to make that happen. And so wanted to really try to identify what we think are some of those best practices and leading examples so that states could look at that and help develop a plan. For states that participate in the Money Follows the Person grant, which has been successful in helping transition individuals back out of institutional settings into the community, we recently made additional funding available to each grantee to help spur planning efforts around how to accelerate some of those rebalancing efforts using some of the existing funding that we're able to reallocate to help try to drive that forward. We're working one-on-one with a number of states who are looking at making this a priority to give them the support and tools that they need, but I think the tools are there. It's just a question of really prioritizing that and making that investment in time and resources to help move the needle. The other thing I would say too is, there's always going to be an important role for nursing facilities and other institutional settings to care for some of our most complex patients. And so we've got to make sure that we have high quality, safe settings to do that. And so really encouraging states to think, as we have this conversation about value-based care and reimbursement, I think there's no better place to have that conversation than in our long-term care system. Should a one-star facility be paid the same as a five-star facility? How are we incentivizing our providers in terms of investments around quality, infection control, beneficiary quality of life, if we're not tying our reimbursement to those types of outcomes that we want to see? Now, we've got to be smart about that and make sure that we're creating the right incentives and that there's the right resources available. But I think we're definitely going to be encouraging states to think about how to tie reimbursement for long-term care services, including nursing homes, to those types of outcomes that we want to achieve.
Well, I think you're going to see a lot around that space, specifically related to a lot of states as well. I think you're going to see what you're talking about, Calder, begin to raise its head in some probably bill filings, not just in the state of Texas, but I think across the country, as that has quite exposed some of the issues within the institutional care area. There was a follow-up question here. Does CMS plan on providing tools or guidance on considering social determinants of health and Medicaid?
We sure do, actually. That is something that we were working on even before COVID hit. Obviously, a lot of our resources and priorities shifted at that point, but we have returned to that work and look forward to hopefully soon releasing that guidance to try and give states, again, a reflection of what we think are some of the promising and best practices that we've seen states deploy in Medicaid, outline what we think is possible under the existing federal regulatory authorities, and kind of how they apply in terms of which populations they can apply to, which services that can be funded, but also expressing, I think, some broader principles that are going to be important as we think about these investments, right? We don't want Medicaid to just supplant other types of federal or state, funding sources, and, start paying for things that, really aren't directly within our purview. We do want to create incentives for states, for plans, for providers to think about the needs of a person and how they can drive down costs and improve quality holistically, and give them the flexibility to make those investments in a way that's going to be cost effective and sustainable. And so I think, and also making sure that it's targeted to the right populations where that need exists and where the outcome is going to be what we expect it to be. So a lot of really strong emphasis on evaluation, being data-driven, being targeted, and making sure that we're not just opening up, holistic new programs that all of a sudden are going to have folks coming out of the woodwork to access services, and then it's going to become unsustainable from a funding perspective. So that will be the kind of focus that we have on this, and I think it ties very directly back into the conversation we were just having around value, because, when we move toward a more value-driven reimbursement system for the healthcare system overall, I think that alone will enable a lot more investment into addressing some of these issues that we talk about in terms of social determinants of health, because you do have accountability for total cost of care in some cases. And so you're thinking about those drivers more effectively. So I think those conversations go hand in hand.
So last question, I promise, as well as we are winding up here. With the opportunities of COVID, give me one impact that you see because of the opportunities that COVID has presented to us with healthcare in the future.
Well, I think we've talked about two of the biggest ones, which is, of course, kind of the permanency around the telehealth revolution that's occurred in the last 9 months, and really moving toward a steady state when it comes to what that looks like, and making sure that it's a tool to help close disparities in the healthcare system across the board is going to be really important. As an opportunity, it would be a terrible missed one. The other we talked about, I think, is around the long-term care system in this country, and really using this as an opportunity and impetus to accelerate efforts around rebalancing, improving quality, and making sure that our dollars are incentivizing the types of outcomes that our loved ones deserve, no matter what setting they're being served in. And then I think the third opportunity is really, I think it's learning how to work together more effectively, at least from the Medicaid side. I think we've demonstrated that, historically, of course, waivers take months to negotiate. State plans can have 2 90-day clocks. We took steps early on to say, we think that these are the types of flexibility states can use, created a range and gave states templates and said, kind of decide what works for you, and we're going to expedite this process. We, as a result, I think, of our efforts to improve some of our internal business processes, had reorganized all of our regional offices now report into one integrated infrastructure, one Medicaid team that's organized by function. And so can work consistently across the state, and be a little bit more responsive, I think, to states' needs. So I think we've learned that we can work differently and smarter and more effectively in terms of that state-federal partnership. So I hope we can derive those lessons learned and make them permanent as we move beyond just the emergency situation we're faced with.
Well, Calder, I have to say thank you very much for joining us. I like the picture in the background with the pelican as well, so go Louisiana. But thank you for joining us today. For you that are on the call, the next panel is scheduled in about 3 minutes. And it will be a conversation with national public health experts on the challenges and opportunities due to COVID-19 and what's next for healthcare. So join us at 3 o'clock. It's another link that was already emailed to you as well. But thank you for joining us today. And Calder, thank you very much for joining us.
Thanks, Asbel. Great. Thank you for having me. It was great to be here.
Stay safe.